Welcome to our session today, Patient Perspectives on COVID-19 and Access to Care. I'm Mark Skinner. I'm from the United States with a long history of involvement in the hemophilia community, and I'll be moderating today's session. We're all living in really challenging and extraordinary times, but it's even unique and more so challenging for those of us that live with plasma disorders or those that are dependent upon plasma derivatives for our health, our well-being, and our survival. So today's discussion is going to be among 5 patients, including myself, that are living with various disorders. And we want to talk about how COVID-19 has impacted us, some of our lessons learned, some of the challenges, and some of the things that we hope to achieve as we go forward. So our panel today includes John Boyle. John is President and CEO of the U.S. Immune Deficiency Foundation. We're also joined by Martine Projet, who is chair of the International Patient Organization for Primary Immune Deficiencies, IPOPI. Jim Crone is president of GBS CIDP, the foundation of the International Board of Directors. And Michelle Couvet, who is the Senior Executive Vice President and Chief Operating Officer of the U.S. Hereditary Angioedema Association. Thanks to each of you today for being with us. And we certainly would all love to be together, but hopefully through this virtual format, we will be able to have an interactive conversation. We don't have formal presentations planned today. It'll be entirely a discussion and a question and answer. And I've asked each of my colleagues to jump in and share their thoughts. So I think the first thing that is important for the audience, which hopefully is intuitive to all of you, is why is there a patient panel? And why are we kicking off this conference? And so certainly we are all concerned about our own health and our access to healthcare during these challenging times. But for those of us that are living with a chronic disease, it really is all the more important. I mean, ultimately, the work that each of you do and those of us that are living within the community is the health and well-being of the individuals. And ultimately, the manufacturers in the business to make our lives better and to improve our quality of life. So each of the organizations that we represent, as well as our brothers and sisters in other organizations in the plasma world, have a long-standing relationship working together, as well as working with industry trade organizations such as PPTA. We participate in the American Plasma User Coalition, which is a national coalition within the United States and North America of patients that are dependent upon the life-saving plasma protein therapies, representing about 125,000 American lives. And then within Europe, the PLUS group, the Platform of Plasma Protein Users, is a parallel consortium of people living with similar disorders and representing about 110,000 Europeans across the continent. And together we work closely and regularly meet to discuss issues of shared concern. And certainly COVID-19 has been at the top of that list over the last year. So today we really want to touch on several conversations. It'll be a little bit of a free flow, but we want to talk about the safety of the products. We want to talk about our access to therapy. We want to talk about concerns about supply, continuity of care, what it means for our day-to-day access to treatment. And then we want to share some of our advocacy initiatives, those that we've been able to address, as well as some of our ongoing concerns. So let's jump into our first theme, and that is safety. And I think the first question that all of us ask when COVID-19 came onto the horizon is, what does it mean for our individual safety? What does it mean for those of us that are dependent upon plasma therapies? Is it transmissible? How is it transmissible? Is it transmissible by blood? Is it transmissible by plasma? Is it transmissible by the plasma-derived medicinal products? Are we potentially facing the next HIV or hepatitis endemic if in fact it is transmissible? And what would that mean for our continuity of care? Certainly, it is was a time of high anxiety, of concern, of worry. We see a lot of new pathogens that come about, and we immediately want to know, is it transmissible, and should we interrupt our care? Should we alter our care? And while we're certainly focused on ourselves, on our own health, we're also equally mindful that it is important that we think about the donors, those who make the life-saving gift of their plasma or their blood that leads to the therapies on which we rely. So really thinking about the entire ecosystem. And COVID has presented some very unique challenges for us that have been different from past viruses that have arisen. I want to thank PPTA and IPFA, the two leading trade associations that work in this space, for their early work and reassurances, as well as the regulatory partners at the FDA and the EMA. One of the early things, as I mentioned, that we wanted to know is COVID transmissible? And we received really early reassurances that the history of past coronaviruses, whether it's within SARS or MERS, there is no history of them being transmissible in blood or plasma, and that there are no reported cases of transfusion-transmitted coronaviruses. Equally, PPTA issued a very early statement which provided comfort and reassurance that based on their research that the SARS-CoV-2 outbreak should not be a concern for plasma protein therapies, that the viral inactivation and elimination procedures that are employed in the manufacturing process for plasma-derived medicinal products are sufficient to destroy envelope-lipid viruses like COVID-19. So that really allowed us to shift our focus to what does it mean for the safety and exposure for the donors, for us as individuals, how we access our treatment, and what might it mean for the supply of products. One of the long-standing tenets of our community is it's not just the safety of the individual products, but supply of products itself is a safety issue. And so we became immediately concerned after we resolved the question of the safety of the products themselves, is what does it mean for the supply or the continuity of products? And what did we know about that? So early in the pandemic, we saw patients and individuals, and probably many of our friends, even outside of the community, started looking for a safe haven. Where could they go where they would reduce the risk or their exposure? So I'd like to jump into the conversation now with my colleagues and begin to think about some of the supply and continuity of care issues. And I wonder if maybe I could go first to Martine. Based on your populations, your patient populations community, what did you begin to think about in terms of the supply issues as it met the safety and the health of the patient population you represent?
Thank you, Mark, and hi, everyone. Very happy to be there. Yes, of course, when we had that pandemic happening, the first thing we thought of was the safety of the products, because, of course, our patients are really have a lot of anxiety on that. And we know, when we knew about the virus and the fact that it was a coronavirus, of course, we know also that the viral safety of PDIMP is well established, with no viral transmission since the early 90s in well-regulated markets. And this is something that I need to add. But before I speak about the well-regulated market or the non-ones, I would like also to stress the fact that we definitely need to differentiate blood products from stable plasma medicinal products in this type of discussions. And because of our advocacy action, we can see that it's not in the head of many decision makers. and we have a lot of work to do, so to make the difference between the two types of human products, because this is a really important difference, and we need that the decision makers have this in their head to take the appropriate decision when it comes to especially safety, but also supply. Overall, the supply has for many years become the main safety issue. And when we speak about safety, it's mainly now about supply. Just I was saying about the viral safety issues may arise in case-by-case basis in less well-regulated countries. For example, we just were noticed about Brazil importing of untranslated Chinese IG therapies without authorization from the Brazilian regulatory agency. And of course, this raises concerns currently. And this is the kind of thing that happens in some part of the world, and which we should be aware of and advocate against that. That said, I think that really this is important to see that nobody speaks about compensating plasma, because at first, when it comes to hyperimmune and convalescent plasma, nobody has any worry about the fact that maybe those people who donate and are compensated could provide less valid resource. And I think that's something that should be always put forward, that the welfare of the patient should be the primary consideration in decision-making around the access and supply. No one is asking for those new therapies, new inter brackets, because of course this is not. So I think that's really now the problem is the supply for us. And this is a safety issue indeed.
So I think you've nicely summarized sort of the range of issues which created almost the perfect storm. All of the issues that we've talked about as a patient community, whether it's the availability of donors, the safety of the products, the ability to get to the products to the patients that they need, getting them the right product in the right setting, have all converged and created a series of challenges for us. I think underscoring that is, what are the facts that we know? The fragility of supply for patients, I think, has really become a dominant issue for us. And I'm wondering if one of the other colleagues could maybe share their thoughts. Did you have the information and the knowledge that you needed to know what the supply line looked like? That if plasma collection was interrupted, did the community really feel prepared, or are there some lessons that we could be learning here about the impact on donor collection? Calls went out early for blood centers who were seeing a drop in supply, but we really didn't have good information about what it meant for the supply of plasma donors. Any thoughts about data information from John or Jim or Michelle?
Sure. I'll maybe start this off. At the Immune Deficiency Foundation, we have very good relationships with both the individual manufacturers as well as PPTA, as well as the FDA and the office CBER, or the Center CBER, I should say. And everyone is aware, and everyone has a certain amount of their own data. A lot of it is retrospective in terms of industry, in terms of collections versus the finished product. And so everyone had their own piece of the pie, but there was really, and we've seen this in the past, there are very few timely and accurate ways of, I think, comparing notes and getting the full picture, which really from the get-go was very worrying to, I think, a number of us who represent patient populations. We understand that there are limits based on the sort of antitrust safeguards that are put in place with the industry members and the role of the FDA versus the individual companies. And in more normal times, or when a situation is a little bit less acute, as it is here. That's one thing. But I have likened the situation really from the get-go, where it appeared that plasma donations were going to be slowing down because of people's access, to a freight train that was coming. We all know that there is something that is coming down the pike. There is going to be a problem appearing, and everyone has these different pieces of data, but there are no safe harbors that are easily able to be put in place, and maybe most importantly, spoken about publicly, or at least beyond the group of insiders. Many of the people represented here have, maybe are able to get some very much on deep background information, which is very limited and can't necessarily be verified. But when it comes to actually naming the pain and really assessing what is the situation, how does it compare, it's really difficult to do. And I think that is something that as we go through this and build for the future, we have to really urge both those in industry and those in government to make it possible to really change that. So when there is an emergency, people are not pointing fingers at one another saying, well, I couldn't share this, or we didn't have a way of doing this, because we know the problem that is potentially facing us. And if everyone is holding on to their information and does not have a way to safely share it, then it's not going to do anyone any good. And we're going to find ourselves with a real problem, once it truly is there. And in retrospect, I think people will then come up with some solutions saying, well, maybe we could have done that. This is the time for those in government and those in industry, and for us as patients, to push, saying, we know that this is coming. You know that this is coming. We have to have creative solutions to actually getting the data, so we have at least some better sense of where it is that we're going to need to go, and maybe who it is that we're going to need to inspire to help us to work through this the best as we can.
So it sounds like we're not out of the woods yet. We're still living with retrospective data. We see in the news every day about the second wave. We're seeing peaks again in many parts of the United States, and the U.S. is the largest supplier of plasma. So what does this mean for the future? Do we have any more clarity now than we did at the beginning of the pandemic, what it might mean 6 months from now for treatment availability? Anybody want to jump in and offer a thought?
I was going to jump in and just echo, John's comments pertaining just to being able to synthesize all the data and the lack thereof. We've had positive conversations both with, trade associations, PPTA, of course, and as well as the manufacturers. And while we have received information pertaining to that, it's a little bit, how do you tie all those pieces together, as John pointed out. But to Mark's point, really, we were already in the GBS CIDP community seeing supply issues even prior to a COVID-19 outbreak, in terms of patients being unable to, and we can talk a little bit more about this in terms of their care setting and things like that when we get into some of the other topics. But this was already happening, and if anything, COVID-19 has sort of cast a beacon of light on the issue, where we can utilize this as a platform to raise awareness about issues like you mentioned, the world being heavily dependent on U.S.-based plasma. And if we're still living in areas here in the U.S. that are shut down, or people are not being asked to move from place to place, or we have physical distancing, you think about what that may mean in terms of a donor center. Do they now have to space collection beds or stations farther apart? Things of that nature. Are people less likely to go out? And really calling into question some of the same age-old debates that we've had about non-remuneration and things of that nature into this. And what will that mean? I think we still don't know. As we know that the process to make a lot of these plasma-derived therapies is months long, and we're now 6 to 9 months into this pandemic, if not longer, and we'll start seeing some of that. So it's going to take a while even to capture all the data and to recover, even once we turn that curve, or the curve starts in a downward trajectory. We have a vaccine, herd immunity, what have you.
Yeah, so the hemophilia community is fortunate to have a range of therapeutic options available. We have recombinant products in addition to the plasma products. That's not true for all of the bleeding disorders. There's a lot of rare bleeding disorders that are solely dependent upon plasma therapies. I know that varies among our patient populations. Michelle, I'm just wondering if you could comment, as we think about contingency planning for a new virus or a pandemic like this, how can the community prepare? What kind of information do we need to hear from industry that allows you to think about what's care going to be like 6 months or a year from now? As patient leaders, we have to look at the long horizon, not where am I going to get my next treatment tomorrow or next week, but what kind of information would you like to see for the future?
Thanks, Mark. And like John and the others, the HAA, we also have close relationships with the manufacturers. We create touch points on a regular basis since the pandemic started to make sure and to check. Do you have a supply issue? Are there any problems in the foreseeable future? Like we do have other products or other therapies, but any disruption, right? Any disruption to the supply is going to have a serious impact. So we, as an organization, we poll the community as well. We check to see, are you seeing any disruptions pre-COVID, post-COVID? What can we do to help? And then we take that information back to the manufacturers, to organizations like PPTA, and we share those findings so that we are able to better prepare the community so that, in some cases, there's been reports of medicine hoarding, right? Patients are scared that they're not going to see their therapy, that they're not going to have access to them. And so how do we communicate the information that we're receiving, not only from the manufacturers, but also from government in terms of what is safety going to be like? What is that access to those therapies going to be like? Somebody mentioned social distancing, right? And so with the safer at home orders, a lot of donors were not able to go to the collection centers to be able to make their donations, to give their donations of plasma. So being able to communicate the safety of getting to a center and that you're going to be safe during that period of time that you're donating plasma is also going to be important, so that people are feeling at ease, that they're not, in their best of intentions to donate plasma, that they're putting themselves at risk. And I think that it's kind of a collective effort that has to come from everybody in order to make sure that the distribution is not interrupted along the way.
And which I think raises really some important issues, because we all work with our global organizations. And while I mentioned that, we come from US and Europe, we're mindful that the disorders or diseases that we live with are not limited. And the interruptions in the global transportation network had profound implications for our patient communities. I know within the hemophilia community, we run a very large humanitarian aid program, and just simply the shutdown of airports and transportation networks made it very difficult for us to move product to parts of Asia, Africa, Latin America, where patients were in need. When governments aren't purchasing, when they don't have the ability either to go by land or air, or if they only purchase limited quantities at a time, that ability to resupply, even if it's available, highlighted a fragile aspect of our care. I know there were a number of cross-border issues as borders closed in Europe about where was the product depoted and how could we move that product. I think the interconnectivity of our community and the migration of plasma are issues that are unique to our population, that are distinct from the blood community. And so highlighting those issues, I think, has been a unique challenge and opportunity for us to educate policymakers.
Mark, I was going to add, one thing that we saw in the GBS CIDP community, specifically relates to GBS. It's usually preceded by an infection of some sort. And if you go back to the global health issue that was facing the world several years ago, Zika infection, that was the big headline grabber. At that point, there was a direct correlation between Zika and onset of Guillain-Barré. And so we think about supply issues, and there was at that time concern about, is there enough supply of product? With now, in some cases, we had evidence in Puerto Rico, for instance, back in with Zika, that there was a 20-fold increase in incidence rate with Guillain-Barré based on Zika. And so immediately the community, when they had heard of another public health crisis coming on, asked questions naturally that would come to mind in terms of, is this another thing that could cause a disruption or supply in the marketplace when we're already living in a constrained market. And thankfully, I'm happy to report that while there are a few anecdotal case reports, less than 40, there really isn't, but it still raises that question, or as a patient, that fear is still there for some of them, that it could have caused a supply issue going forward.
Well, once convalescent plasma is approved also for the cure of COVID, you are going to see, a heavier burden, right? You have 34,000 people in the United States that are currently hospitalized. And if, as in absence of a vaccine, convalescent plasma is being used to treat patients in order to improve their care, then that division, those donations are going to be somewhat, divided.
And I think that really raises the question. While I think many of us were, really pleased and gratified that the community in which we live and work was going to provide part of the solution for COVID. So the ability for convalescent plasma, which then could contribute to the production of hyperimmunes, which may ultimately be a viable treatment, seemed reassuring. But you've highlighted the flip side of that issue is, what does that loss of donors mean for the production of IVIG, which was already in short supply? And how do we balance that? And what, if any, influence do we have as a patient population to break through that that sort of campaign to make sure that source plasma donors are not lost for our patient community?
Mm-hmm. Yeah, this is a nice side of the story, if I may say so, that the plasma and the immunoglobulin especially have made people more aware about that kind of treatment, because beforehand, nobody knew about that outside of our communities, of course. I would like to add something about the fact that our patients don't have any alternative treatment, but we use a medicine which is used by many other people with many other conditions. And this is really difficult in many countries to know how much allocate for the patient who really do need it, because they have no alternative treatment. And this is the reason why we really think that we must push the fact that the countries, the health authorities should have demand management plans for those who have no alternative treatment. And there is also something else I would like to say. Because of COVID, we have many patients who had to switch from IVIG, from subcutaneous to IVIG, because subcutaneous has a very, very high tension in many countries. And in some countries, the price of these products can be the double of IVIG. So you see, this is a real big difference. And I think this is really important also to put on the place that the life of patients who are used to get their treatment at home and have to move to hospital again, this is an added burden to the COVID-19, especially when you don't like to travel and especially go to a hospital during those time of a pandemic.
So continuity of care is, has been central for all of us. These are life-saving therapies for us. And it's not just that you have access to treatment, but that you have access to the right treatment. And so, my understanding is staying on the treatment which works for you is fundamentally important for the immunocompromised community. And so maybe one of you could share a little bit what it means that if you're on home care, on a subcut therapy, or have home care, and you have to transition, what does that mean in terms of the daily life of a patient, in terms of time and burden? You've already talked about cost and the concerns about insurance, but is that an easy switch? Can you move back and forth between treatments seamlessly? John?
Not really. And it does depend. I mean, because again, in the United States, which is a bit different than most of the European countries, in terms of the insurance barriers and all of the other logistics there, it is possible in some cases, but then again, you get issues of formularies where the insurance that you have says, well, no, there's only this one IVIG or this one subcutaneous, and the ripple effect. And this is one of the real things that I would like to make sure everyone watching is very well aware of, because we saw a bit of this here in the U.S. and then to a degree in Europe about 2 years ago, where subcutaneous first became in somewhat shorter supply, and there was then a ripple effect to IVIG. A little bit later, as people were kind of, the one end of the balloon was squeezed and then the other one kind of inflated, that there are so many challenges. It's great that we have both subcutaneous and IVIG, but there are multiple products. There are different price points. There's distribution and contracting that is all involved. And when you have a situation like we had a couple of years ago, where the issue was just that the demand was slightly outpacing the supply, that created, some really terrible complications where, you get someone who is meant to get their subcutaneous and they're told basically by their pharmacy, no, we don't have that for you. So we're going to have to send you over to this doctor's office or to this hospital. And again, for an immunocompromised person, that's a very bad idea. What we may be facing here goes beyond, that normal level and that normal concern of the best therapy in the best site of care that is right for you and that you and your doctor agree. That should be the ideal. The problem is that given this ripple effect of, and it's global, if certain product is going to the United States that might otherwise be going to countries in Europe or elsewhere, I hate to say, and I really am loath to say it, those issues are secondary. The real issue for those of us who truly rely on these therapies, such as antibody replacement with primary immunodeficiency, it becomes any port in a storm. We need to get our product. And when our insurance companies or our health ministries are saying, well, we don't have the access to it, it becomes a ticking clock. And I think that one of the pieces, as we talk about educating, the government officials and those around us, including potential donors, is the urgency issue. I mean, this is again a potential train coming. We've got to get out of the way as best as possible, because you will get into a situation where you show up for your infusion and you're told, we don't have it for you. And not just we don't have your product, but we can't get access to any product because this hospital or this country or whatever it may be, they're getting it, or we don't know where to get it. There is none to be gotten. And so, ideally, going to the place that is going to be safest for you, that is, least disruptive to your life. If you're getting subcutaneous, again, you can do it at home. You can do it by yourself. You don't have to get a nurse or go into a clinic or anything like that. For young people, trying to go through college, trying to go through school, that's critical. For people who are trying to work, that is absolutely critical. But I hate to say that, with what it is that we could be facing, it is almost secondary because of just the plain access to any product in a timely manner. And of course, the only seeming ways to course, get out of this and to ameliorate that over the long term are, as was mentioned before, I think by Martine, the sort of management system, of making sure that the right patients are getting these therapies, but also just plain inspiring more people to donate. And of course, that gets into the education discussions, which we were talking about before, of both blood and convalescent plasma, and then of course, source plasma. And there is, I think, a lot more to be done there.
And so enormous issues of health equity come up at a time like this, not only within a country, but globally. It's hard to imagine that the manufacturers are going to be out robustly developing new tenders and new markets around the world, that our ability to progress and provide access and care for previously unserved populations may be constrained or slowed, which I expect is troubling to all of us. And we've talked previously about when a new patient is diagnosed in the midst of COVID, what's the ability to bring treatment to a new patient? One, is the product available? And two, what care and education is required? In the hemophilia community, you learn to self-infuse. You do that within a clinical setting. And are patients going to be willing or able to go and learn to do that home care and that access? Are you going to be inviting a home care nurse or somebody into your home at this time to bring you therapy if you're not able to self-manage and self-infuse? I'm wondering if any of you can sort of share thoughts, whether you've heard any stories about what's going on in government tendering or your experience with newly diagnosed patients. We can't put the world on hold for a year or a year and a half. Any reflections on what's happening for either new patients or countries that are newly interested in treating patients?
But speak to the new patient area, and this even gets to age-old, even here in the United States, just insurance approval issues that have been highlighted. As we know, IVIG is a very expensive product, and we run into patients all the time that are having trouble if they're newly diagnosed, just getting through that pre-approval process to get their therapy, and then dependent upon what that plan may be, where it is that they're supposed to and via what route they're supposed to get infused, that has certainly come up. With GBS, certainly IVIG and plasma exchange are appropriate therapies, and here in the U.S., IVIG is usually the gold standard, that the de facto that folks will go with. In other countries, maybe something a little bit different, but in CIDP, where it's a chronic condition, you're going to have this going on. I think there's a little bit more pressure being applied to maybe if there is a shortage of product, not taking on that patient, maybe trying some other therapies, whether they be steroids, immunosuppressants, things like that, before going to it. But in truth of the matter is that IVIG may be the very best thing out there for the patient, and they may not have access to it. And we want to make sure that they do have access to that in the appropriate setting. Sometimes it is in a hospital setting. Sometimes it is in a home setting. As Mark, I think you said, do you want an external person coming into your home or not? Each patient is unique. Each circumstance is unique. We've even run into some patients who one brand works better than another. I mean, IVIG is IVIG, but they may react in a particular way, and to be told, I'm sorry, you're now going to have to go back to this other formula, this other brand that previously you had documented reactions to, can be frightening to the patient as well. So, or switching the route of infusion and how their body will react to that. I mean, the fact of the matter is, these are not optional treatments. These are things that folks have to have. And I know in all of our communities they're life sustaining. With GBS CIDP or MMN, multifocal motor neuropathy, and it's also served by our foundation, IVIG is it for them, the only option as well. And it's either that or they get the therapy, or they're then hospitalized because they have a progressive weakness. They may become paralyzed, may become ventilator dependent, things of that nature. I've been, personally have been through that and can speak to the importance of that, and to the thought of not having that access to the treatment is scary.
From some countries where we have a total coverage, so the problem is scarcity, because the new patients, for example, they are told, well, you have to wait, just as simple as that. And the other one, they get space between the two cures. So yes, this is another point of view, but even if you have a coverage, a health coverage, you are not saved.
So we're sort of moving to the end of our time block, and I expect we could all talk for a long time. There undoubtedly are advocacy issues that are arising from this that we've really never faced before. It's hard to imagine all of the challenges that we have. We've tried to be great partners, but the amount of work is somewhat daunting. Both in the early access for donors as well as the long-term access. As health budgets become constrained in a post-COVID environment, Jim already mentioned that these are high-cost therapies. We have a new set of worries about our government's going to be able to continue to afford these therapies along with all the other needs. I'm wondering if we could do just sort of a quick around the table and have each of you give sort of a short parting thought, a message to the audience, either on your reflection on what's occurred or what you would like to occur. So maybe Jim, we'll just sort of start with you.
I think my closing thought would be I mean, this is certainly, COVID has been a devastating situation worldwide, and the more, if we can get anything positive out of it, is the educational component around it, and bring folks who may not have otherwise donated into the fold, explain the importance of that, and the therapies and conditions that we have, and really utilize that to raise awareness about the topics that we're talking about here today, because they won't subside when COVID-19 subsides, hopefully. But we have a platform at this point, and hopefully we can utilize that to raise awareness and get more folks educated about things like, they think when they go to the blood drive and donate whole blood, it's different when you're going to donate source plasma. So really that educational component about our diseases, therapies, and providing source plasma.
Michelle, any thoughts, reflections, aspirations, hopes for the future?
I'm seconding James' statement. Education and awareness. This is it presents an opportunity for us to really spread the word, right, at a more national level, beyond our community, beyond the communities that need the plasma donations for their therapies, so that people understand the value of it, and to go out and regularly donate plasma. Government officials, this is an emergency situation for them, so we don't want them to then move on once COVID does subside or settle down, or we have a cure for it. We want to be able to let them know that these policies need to stay in place for the long run, because there are other communities that really need it, and they are life-saving therapies.
Yeah, thank you. Martine, I know in Europe, World Blood Donor Day this year, it was remarkable, at least to me. For the first time, they acknowledged plasma collection as a part of World Blood Donor Day. Any thoughts for the future about how this is going to move forward? Yeah,
COVID shows that or highlights what existing before, the problems that existed before. We need more plasma, as simple as that. And we rely far too much to the US donors in Europe especially, but in all the world regions. And I think it's not fair, nor for us, nor for them. And I think that we need to tackle the barriers and achieve a regionally balanced plasma collection to reach PDMP's global sufficiency, because this is key.
John, any words of wisdom for us or our listening audience?
Well, let me just take what Martine said another step further. I mean, this is a cautionary tale, and those outside of the U.S. especially need to take note because the dancing around the issues of national sufficiency and setting goals and creating policies that are, based in, of course, some beneficial factors, have all been, as far as I can see, and I will be the brusque American here, ignoring the reality of what could happen when a somewhat worst case scenario, which I think is what we are potentially facing here. What if the U.S. supply becomes too short? The entire Western world has put their eggs in the basket of the United States supplying the plasma, in part because we compensate, in part because of the investment of plasma collection facilities. And when that goes wrong, which it is going wrong right now, when there is a gap in there, the ripples are enormous. And so to those in Canada, to those in Europe, to those all over the world who are grappling with these issues of plasma donors, of national culture and everything else, please, for the love of all that is holy, think about the patients who are on the other end, because we are the ones. I lived through a shortage in the 1990s, which, again, it was tough. And I had the ability to really advocate for myself. And so many of our organizations are great at doing it. But when the raw material is not there and the need for these therapies is great, it becomes that much more obvious that patients are going to go without. They are going to space out their infusions. They are going to be putting their health at risk because there is no option. This is not their choice. This is the hand that they have been dealt. So the entire global community needs to take note of what we are dealing with right now and reassess what is actually best for those who rely on these therapies, to give that more weight. And again, as they do, and as hopefully some lessons are learned about the ramifications of these decisions, or these what have, I think at some level, been academic conversations. Right now, it is being grounded in the reality of what is going to happen in the months to come. So with that, I just am hopeful that, again, countries all around the world take note of this, and that for those countries, especially the US, where there is collection, and there's an ability to hopefully ramp it up, even with the concerns that people have of social distancing and going out, for people to take note of where the plasma collection centers are. PPTA has a phenomenal website of donatingplasma.org. The Immune Deficiency Foundation has created the plasmahero.org website, which is kind of taking a slightly different tack. So many of the organizations are trying to inspire plasma donations within their countries and communities. The urgency of people taking note of where those plasma donation centers are and then actually going and donating. The companies, the countries, we as patients, we need to pull out all the stops. This is the time to inspire people to change their actions, to go to a donation center or to lobby their national health authority to make sure that they are being taken care of the way that they need to, so that when this train arrives, we are not going to find ourselves in the worst possible situation that we might.
Yeah, well, so thank you for those comments. I think probably on behalf of all of us, we would all be remiss if we didn't have a big thank you to the donors that really are stepping up right now. They're making an enormous difference. You've highlighted very well the need for more. And if there's a way to make lemonade out of the lemons that COVID has brought us, or to find that silver lining, perhaps it is the coalescence of many of the longstanding issues we've had in the community. That as patient organizations, as individual patients, we want to be partners in our healthcare. We want to continue to partner with industry, and we thank PPTA and their members for allowing us to do that. We do need greater transparency. We need greater access to data so that we can plan, so that we can do the pandemic preparedness, the contingency planning that is critical, and hopefully you've understood the worries. Supply is fragile. We have enormous dependence on the United States and a limited number of donors. And hopefully this awareness and the collaboration that's been developed through COVID will allow us to think more globally and less nationally. We need global sufficiency, and that does require governments and ministries to rethink how they think about blood and plasma and the unique challenges of plasma. There's certainly been encouraging signs. Sustaining that momentum is our goal. It's not over. We still have concerns. So many of the issues we've talked about are still clear and present, but hopefully by collaboration, we can get through this together. I want to thank all of the panel for today, and hopefully each of you will have success, stay healthy and safe, and thank you to our audience. Each of us are individually available and would love to continue this conversation one-on-one. So thank you, and enjoy the rest of your day and the rest of the meeting.